So facial nerve, okay, facial nerve, the most important nerve for your um, university exam. Okay, so facial nerve, the important thing you have to know before going to exam is muscle supplied by facial nerve, sensory supply of facial nerve, and it also has a parasympathetic innervation. So this is very, very important once you go for exam. Okay, so where this facial nerve is going to enter? This facial nerve is going to enter at the pons, okay, and they form a loop around the sixth nerve, and it is called as uh, facial colliculus, okay, facial colliculus, and then it enters into the internal acoustic meatus and then into the facial canal, okay. So it is going to be giving nerve to lacrimal gland just before entering, okay, and then it is going to form the important thing which is going to be nerve to stapedius. At the same time, it is going to receive innervation from cauda tympani. Okay, cauda tympani. If you see here, it is going to be this picture is not given. Okay, so it is going to be giving nerve supply to the lacrimal gland. Okay, lacrimal gland, and then it is going to go and give nerve to cauda tympani and your stapedius muscle, and then it is going to enter into the stylomastoid foramen, and from the stylomastoid foramen it is going to give into two branches. From there it is going to give five branches. Okay, this five branches looks like the feet of a crow, so it is also called as pens anserinus. Pes anserinus. Okay, it is also called as pes anserinus. Okay, this and all you would have known. Okay, so what are the branches it is going to give? Okay, so it is going to give branches which are going to supply frontalis, orbicularis oculi, buccinator, orbicularis oris, and platysma muscle. So these are the important muscles you have to know. Okay, and the facial nerve supply gives motor and parasympathetic fibers to lacrimal gland, submandibular gland, and sublingual salivary gland, and it also carries taste sensation from the anterior two-third of the tongue through cauda tympani. Cauda tympani. Then upper motor neuron, lower motor neuron. Yesterday I have discussed actually, I think so to you. So in upper motor neuron, it involves the lower part of the face. In okay, so in lower motor neuron, it is going to involve the upper part of the face and the lower part of the face. Both together will be involved. Okay, so that is going to be your uh, facial nerve. Okay, facial nerve. Okay, so this is very, very important thing to know. So facial nerve, whenever there is a facial nerve palsy, okay, whenever there is a facial nerve palsy, the facial nerve palsy, it is going to be UMN type, LMN type. In UMN, lower part of the face is involved. LMN, whole face is involved. Okay, now what are the tests you're going to do? Okay, so whenever you have a patient coming to you with facial nerve palsy, the first thing is you observe. Okay, you tell the patient to look upwards. Okay, so whenever there is a facial nerve palsy, okay, whether it is LMN or human. Okay, human. Okay, once again. Whether it is going to involve the the element type or human type, you have to check for all the muscles. Okay, the first thing is whenever you tell the patient to look upwards, okay, whenever you tell the patient to look upwards, so what happens due to the involvement of frontal belly of occipital frontalis, there is going to be loss of wrinkles in the forehead. That is the first thing. Okay, then second thing, okay, the patient will not be able to close the eye. This is due to involvement of orbicularis oculi. Okay. Uh, then deviation, next is going to be flattering of the nasolabial fold. Okay, this is due to ala nasiae. Ala. Okay, then you can see the patient having deviation of mouth to normal side. Okay, deviation of the mouth to normal side, because one side muscle is not working means the other side will try to pull. Okay, this is going to be orbicularis oris. Okay, the same thing, the patient is not able to, okay, able to make the pursing of the lips. Okay, pursing of the lips also will not be able to be done. Okay, then next is the patient will have inability to close the mouth. Okay, close the mouth, and the patient is not able to fill air. Okay, close mouth and fill air, or leakage of air. This is due to buccinator. Vaccinator. Okay, then there should be diminished corneal reflex. Okay, diminished corneal reflex. Okay, decreased lacrimation, loss of taste sensation over the antidote of the tongue, and hyperacusis. Okay, so this is going to be again due to the parasympathetic involvement, and this is due to involvement of the muscle to the trapezius. Okay, so this is going to be involved. Okay, so whenever there is a complete facial palsy which is idiopathic in origin, so இது நிறைய பேர் சொல்லவே மாட்டாங்க எக்ஸாம்ல. Okay, it is idiopathic in origin. Idiopathic element facial nerve palsy. Okay, idiopathic element facial nerve palsy is called as Bell's palsy. Bell's palsy. Okay, that is very, very important. Okay, so whenever the lesion is outside the stylomastoid foramen, okay, stylomastoid foramen, that is, if you take the parotid line, the parotid gland will be like this, and your facial nerve is going to enter like this. Okay, whenever it is outside the stylomastoforamen, okay, then you are going to have all these features involved. Okay, and important thing in your exam is going to be, they are going to ask you what are the conditions where you're going to get bilateral element type of facial nerve palsy. Okay, so நிச்சயமா இது சொல்லணும். Okay, so என்னென்ன சொல்லணும்? GHSL. Okay, Guillain-Barré syndrome, HIV, sarcoidosis, Lyme's disease. Bilateral human type of facial nerve palsy கேக்குறாங்க. Bilateral human type of facial nerve palsy கேட்டாங்கன்னா, then your answer is going to be, importantly, I'm going to say multiple sclerosis. இதை include பண்ணணும். Okay, so these are the few things which are very, very important for your exam. Okay, very, very important for your exam. Okay, so this is going to be very, very important. Okay, so எப்படி வந்து stapedius இது பண்ணணும்னா, you have to swap your fingers like this. When you swap the fingers like this, the patient feels like the sound is very big. Okay, that is going to be indicating hyperacusis. Okay, so this here the whole face is involved. This is going to be element type of facial nerve palsy. Here only the lower part of the face is involved, and it is going to be human type of facial nerve palsy. Okay, human type of facial nerve palsy. Okay, so this is very, very, very important thing for your exam. Okay, so coming to the next nerve, which is going to be eighth nerve. Okay, this eighth nerve has two parts. One is cochlear part, another is vestibular part. Okay, cochlear branch is responsible for hearing and vestibular part is responsible for balance. Okay, so balance, whenever it is lost, it is felt by the person as dizziness. Okay, so how you are going to ask the history in the patient? Okay, so vertigoன்னு சொல்லுவாங்க, நீங்க vertigo பார்க்கணும், அதுக்கப்புறம் nystagmus பார்க்கணும். So nystagmus நிச்சயமா எக்ஸாம்ல வந்து உங்களுக்கு எக்ஸாம்ல கேட்க சான்ஸ் இருக்கு. Okay, if you're answering everything nicely, then examiner is going to ask about nystagmus. Okay, so nystagmus. Okay, so whenever you are going to check for nystagmus, you are going to make the patient seated. Okay, the patient is seated. Okay, now what happens whenever the patient is seated? Okay, you are going to keep the finger at 1 meter distance or an arm's length away. Okay, then what you're going to do is you're going to ask the patient to look at the fingertip and you're going to ask the patient to move or follow the finger slowly. Okay, so you go from here and you cross like this and you come like this. Okay, so whenever you look at it, you see for any oscillations. Okay, this oscillation can be an horizontal oscillation, vertical oscillation, or rotating oscillation. Okay, and the direction in which the patient is going to get the nystagmus is also very important. Okay, very important. Okay, then if the nystagmus is always in one eye, then you have to examine for the other eye also. Okay, so what are the types of nystagmus? Okay, you can have a pendular nystagmus. Okay, or you can have a jerky nystagmus. Okay, so pendular nystagmus means it will be like a pendulum. It will go like this and it will come like this. Okay, whereas jerky nystagmus is fast. Okay, fast like this. Okay, it can be a jerky nystagmus or it can be a horizontal nystagmus, vertical nystagmus, rotating nystagmus, or mixed nystagmus. Okay, so the nystagmus can be a unidirectional nystagmus or a bidirectional nystagmus. Okay, so whenever the eye patient moves the eye in one direction, okay, whenever the patient moves the eye in one direction, the nystagmus will occur. Whenever he moves in other direction, the nystagmus will disappear. Okay, whereas bidirectional, okay, whenever the patient moves in this direction or this direction, any direction, he is going to get nystagmus. Okay, whereas here nystagmus is present here, nystagmus is absent here. Okay, so pure vertical nystagmus, okay, occurs with central causes. Okay, pure vertical nystagmus occurs with central causes and mixed nystagmus occurs with peripheral causes. Okay, so you usually whenever central nystagmus it is going to be unidirectional, whenever it is bidirectional it is going to be uh, uh, it's going to be central involvement. Okay, so central involvement will be, okay, central involvement will be bidirectional, okay, or it can be a vertical nystagmus. This vertical nystagmus is also called as upbeating nystagmus or downbeating nystagmus. Okay, so peripheral is unidirectional, central is bidirectional. Okay, so this is very important thing. Okay, central is by BC. Okay, or you remember CBA. Central is bidirectional. Okay, peripheral is unidirectional. Okay, uni. Okay. Okay, central is bidirectional, peripheral is unidirectional, and you can get an upbeating nystagmus or a downbeating nystagmus. Usually, you will get in cerebellar disorders, this upbeating, downbeating nystagmus, and pontomedullary junction tumors or cervicomedullary junction tumors. There you can get vertical nystagmus. Okay, vertical nystagmus. Okay, so this is very important thing. Okay, then what test you are going to do? They can ask you. They are going to ask you Dix Hallpike maneuver. So you tell whenever a patient has benign positional paroxysmal vertigo, then he can have Dix Hallpike test to be done, and it can be positive. Okay, Dix Hallpike test to be done, and it can be positive. Okay, then coming to the patient with hearing, okay, impairment, okay, or whenever the patient has some problem in hearing, then you are going to check for two tests, which is going to be Rennie's test and Weber's test. Why this Rennie's test and Weber's test is done? Okay, so Rennie's and Weber's. Okay, so whenever a patient has hearing loss, it can be a conductive hearing loss or sensorineural hearing loss for that reason. Okay, so how you are going to do here? Okay, so just I will show here. Okay, whenever you are going to have a person like this, okay, you take a tuning fork. Okay, usually the tuning fork is going to be 512 hertz. Okay, so you're going to take a tuning fork which is going to be having a frequency of 512 hertz. Okay, and you're going to keep in the center of the forehead or over the vertex. Okay, whenever you keep it over the center of the head or forehead, okay, forehead or vertex, okay, it is going to be heard equally on both the direction. Okay, equally on both the direction. Okay, whenever it is heard, okay, heard, okay, so in the abnormal ear, okay, whenever it is heard in the abnormal ear better, okay, then it is going to be conductive hearing loss. Whenever there is a lateralization towards the abnormal ear, then it is going to be conductive hearing loss. Whenever the lateralization is towards the normal ear, okay, whenever there is a lateralization towards the normal ear, then it is going to be sensorineural hearing loss. So towards bad ear, okay, conductive hearing loss, towards good ear in sensorineural hearing loss. Okay, bad versus good. Okay, bad versus good. Bad versus good. Okay, hope you're good. Hope you're able to understand. Okay, this is going to be our Rennie's. This is going to be our Weber's test. Okay, coming to the next test, which is going to be Rennie's test. Okay, Rennie's test. How you are going to do Rennie's test? Okay, Rennie's test. Okay, so whenever you want to do a Rennie's test, okay, so what you're going to do is you're going to keep the uh, tuning fork, okay, and what you're going to do is you're going to keep over the bony prominence, okay, bony prominence, okay. Whenever you keep over the bony prominence, the vibrations will stop, and then what you're going to do is you're going to keep the tuning fork near the ear, okay. Now, whenever there is a conduction, it is always bone conduction better. Bone conduction will be there followed by air conduction, okay, and whenever it is happening, air conduction is always better than bone conduction. Okay, air conduction is better than always bone conduction. Okay, so that is the normal perception by the patient. Okay, now this patient can have two types of hearing loss. Okay, two types of hearing loss. Okay, what are the two types of hearing loss? The two types of hearing loss is going to be in the form of conductive hearing loss, sensorineural hearing loss. Okay, sensorineural hearing loss. Okay, now whenever you are going to use, okay, normally, okay, as I told you, air conduction is better than bone conduction. Okay, now what happens whenever a patient has conductive hearing loss? What is going to happen is the patient, after keeping over the bone, when you keep near the ear, the patient is not able to perceive. So here it is going to be bone conduction better than air conduction. Okay, back conduction. Whereas whenever it is going to be sensorineural hearing loss, the bone conduction is here, and then you keep over the air, okay, and the air conduction will be better. So it is air conduction better than bone conduction. Okay, so this is very, very important thing to be known. Okay, so in Rennie's test, bone conduction is better than air conduction. Okay, it is going to be seen in conductive hearing loss. Okay, conductive hearing loss. Okay, so this is very, very, very important. Okay, very, very important. Whereas in sensory hearing loss, air conduction is better than bone conduction. Okay, very, very important thing to know. Very, very important thing to know. Okay, this has to be known by you people, and this you should be able to tell in the exam also. Okay, exam also, that is very, very important. Okay, then coming to the next now, which is going to be ninth and 10th now. Okay, ninth and 10th now. What is the specialty of ninth and 10th now? Okay, whenever you take the ninth and 10th now, this ninth and 10th now are together is will be going everywhere together. Okay, so what happens, it is in the medulla oblongata and it forms a nuclei, but there are multiple nucleus are there. Okay, there are multiple nucleus are there. Okay, the first important nucleus is going to be nucleus ambiguous. Okay, nucleus ambiguous, which is formed by your ninth and 10th nerve, okay, ninth and 10th nerve predominantly. Whereas you have nucleus tractus solitarius, okay, where which is going to be seventh nerve, ninth nerve, and 10th nerve. Okay. Then you're going to have inferior salivary nucleus, which is parasympathetic of ninth nerve, and dorsal nucleus of vagus, which is going to be parasympathetic of the 10th nerve. Okay. So இது எல்லாமே தெரிஞ்சுக்கணும்னு அவசியம் கிடையாது. You have to know about nucleus ambiguous. Okay. Nucleus ambiguous. Okay. So இப்போ nucleus ambiguous பார்த்தீங்கன்னா இது வந்து ஒரு நர்வ் ஃபார்ம் பண்ண போது இது வந்து டேஸ்ட் கேரி பண்ண போது இன்னும் சில ஃபங்க்ஷன்ஸ்லாம் இருக்கு இதுல முக்கியமா கிளாசோபரிஞ்சல் நர்வ் பார்த்துட்டீங்கன்னா கிளாசோபரிஞ்சல் நர்வ் வந்து பாத்தீங்கன்னா இட் இஸ் த சென்சரி ஆஃப் த ஃபேரிங்ஸ் ஓகே மோட்டார் சப்ளை டு த ஸ்டைலோபரிஞ்சஸ் muscle okay stylopharyngeus muscle okay then it is going to be parasympathetic fibers to the parotid gland okay parasympathetic to the parotid gland so நீங்க பாத்தீங்கன்னா facial nerve supplies lacrimal gland submandibular and other minus polar glands whereas parotid gland is supplied by glossopharyngeal nerve okay coming to vagus nerve it's going to be motor okay vagus is more of motor okay வேகமா போகும் so it is motor okay so it is going to be supplying the motor supply to the pharynx etc okay and it also parasympathetic to many organs especially vital organs okay vital organs okay now coming to the examination sequence whenever a patient has a ninth and 10th nerve palsy three things will develop dysarthria dysphagia dysphonia okay so dysarthria means disarticulation of speech okay disarticulation that is a problem in articulation that is called disarticulation in speech the dysarthria is not equal to aphasia அதை ஞாபகம் வச்சுக்கணும் ஃபர்ஸ்ட் இதுல வந்து facial weakness இருக்கு okay facial weakness இருக்குன்னா the patient will develop labile dysarthria okay labile dysarthria na if you tell them to ask them to tell baby hippopotamus okay they will not be able to tell baby ன்னு சொன்னாலே போதும் baby they will not be baby labile okay so their facial muscles are important for telling baby so baby பண்ண முடியாது okay palatal weakness whenever there is palatal weakness whenever it is because of the vagal palsy okay so they will develop palatal dysarthria where the patient will have nasal quality of speech okay they will have nasal quality of speech okay so that is going to be called as a palatal dysarthria then next is lingual means tongue okay so what is going to be tongue okay hypoglossal okay whereas the patient is going to develop problem in L and R okay so whenever you tell the patient to tell yellow lorry they will tell lollo lorry okay so you will not be able to tell yellow lorry yellow lorry like that you will tell okay so that is going to be hypoglossal nerve palsy which is going to be lingual dysarthria okay so you're going to have three types of things okay the first one is facial palatal and lingual okay is very important okay so whenever you are going to check for facial you're going to check the baby yellow lorry okay that is very important okay next is swallowing again swallowing you give 3 spoons of water and whether the patient has difficulty in swallowing okay or there is a cough okay or there is a delayed cough okay with each teaspoon you are going to see okay then uvula normally uvula if you take the uvula whenever you observe the uvula is going to be midline now you tell this patient to tell egg or a okay whenever you tell the patient to tell egg or a okay what happens the pull is equal on both the sides but whenever there is a ninth and 10th nerve palsy what is going to happen is the muscle on opposite side is going to pull like this okay so what happens here is okay what happens here is the deviation towards opposite side that is normal side deviation to the opposite side or normal side will occur whenever you are checking for the ninth and 10th nerve okay then ask the patient to cough whenever the strength of cough is poor okay or the patient has a soundless cough okay soundless cough then it means that patient is having recurrent laryngeal nerve palsy, which is going to be 10th nerve palsy. Okay, then you're going to check for 10th nerve, where you're going to check for the recurrent laryngeal nerve. Whenever the quality of cough is absent, then you're going to be seeing this. Okay, so as I told you, gag reflex. Okay, how you're going to check for gag reflex? That you tell the patient to open the mouth, tell egg, etc., or touch the posterior pharyngeal wall with your uh, cotton swab. Okay, whenever a patient has exaggerated reflex, okay, it is bilateral upper motor neuron type of lesion. Whenever there is an absent gag, okay, it is bilateral element type of palsy. Normal gag, okay, it is will be normal. Okay, normal. Okay, so exaggerated gag reflex can be present, absent gag reflex can be present, normal gag reflex present, or deviation to normal side, then unilateral lesion. Okay, mostly element type of lesion. This is very important. Okay, very important. Okay, so these are very few important things which is going to be seen. Gag reflex வந்து நீங்க எப்பவுமே கையில வந்து ஒரு ஸ்பேச்சுலா எடுத்துட்டு போகணும். ஸ்பேச்சுலா எடுக்காம எக்ஸாமுக்கு போகாதீங்க. certain things examiners will expect you to have. Okay, அதுல ஒன்று வந்து இந்த மாதிரி சின்ன சின்ன விஷயங்கள் வந்து even though it is minor things, they will expect you to have these things. Okay, so this tells about the overall discipline to over 1 year. Okay, so அதனால வந்து கேக் ரிஃப்ளெக்ஸ்லாம் பண்றதுக்கு நீங்க கையில வந்து ஸ்பேச்சுலா, ஒரு ஒரு நீட்டு பட்ஸ் மாதிரி ஒரு இயர் பிக்கிங் இதுல வந்து யூ ஃபிக்ஸ் காட்டன் அண்ட் தென் டேக். Okay, these things are very important when you go for exam. Okay, so this is taking overall. See, one day exam cannot determine the student. Okay, it's about all through the year how the student is. Okay, அது ரொம்ப important. ஓகே, அப்போ அந்த ஆல் த்ரூ த இயர் வந்து எப்படி ஸ்டூடெண்ட் இருக்காங்கன்னு தெரிஞ்சுக்கிறதுக்கு என்னன்னா, இந்த மாதிரி சின்ன டிசிப்ளின்டு ஐட்டம்ஸ் இருந்துச்சுன்னா, ஓகே திஸ் ஸ்டூடெண்ட் இஸ் ஓகே, ஹி இஸ் ஏபிள் டு பெர்ஃபார்ம். ஓகே, சம்வேர் ஹி டஸ் அ மிஸ்டேக், அதர்வைஸ் இஸ் ஓகே அப்படிங்கிற மாதிரி ஒரு இம்ப்ரெஷன் கொடுக்கும். அது ரொம்ப இம்பார்ட்டன்ட். ஓகே, ஸோ திஸ் இஸ் அபவுட் இயர் நைன்த் அண்ட் டென்த் நவ். ஓகே, நைன்த் அண்ட் டென்த் நவ் நிச்சயமா படிச்சுட்டு போங்க. ஓகே, தென் இது பெருசா 11th நவ் ஓகே. ஸோ ட்ரப்பீசியஸ் மசில் பார்க்கறதுக்கு யூ ஹேவ் டு ஸ்ட்ரக் த ஷோல்டர். ஓகே, ஸ்ட்ரக் த shoulder. Okay, then sternocleidomastoid, you have to check for the patient. Okay, sternocleidomastoid wasting இருக்கான்னு பார்க்கணும், weakness இருக்கான்னு பார்க்கணும். Okay, or any kind of head drop இருக்கான்னு பார்க்கணும். Okay, head drop இருக்கான்னு பார்க்கணும். ஸோ இதெல்லாம் வந்து பெருசா கேட்க மாட்டாங்க, அதனால we will skip it. Okay, power வந்து கேட்டா கேட்கலாம். Okay, so power. Okay, whenever you want to test the left sternocleidomastoid, okay, ask the patient to turn towards right and you give resistance. Okay, so whenever you want to check the left sternocleidomastoid, give resistance over the right side of the face and ask the patient to turn towards the right. This muscle will become prominent. If it is not becoming prominent, then it is going to be weakness of sternocleidomastoid. Okay, weakness of sternocleidomastoid. Okay, so these are very important things. Okay, then hypoglossal nerve is a 12th nerve. Okay, it is going to be the nerve which is going to supply all the muscles of the tongue except for stylopharyngeus, which is supplied by the 9th nerve. Okay, 9th nerve is the supplied by supplying the stylopharyngeus. Okay, so whenever okay, okay, you are going to have a tongue like this. Okay, so it has a cross innervation like this. Okay, whenever the patient is going to protrude the tongue, okay, protrude the tongue, the deviation will be seen. Okay, so whenever the patient is going to protrude the tongue, the deviation will be towards same side. Okay, the deviation towards the same side of lesion. Same side of the lesion. Okay, so whenever there is a deviation towards the same side of the lesion, then it means that the patient is having 12th nerve palsy. 12th nerve palsy. Okay, deviation towards same side. Okay, so if this is the patient, okay, so here the deviation is towards the left side. So it is left hypoglossal nerve palsy. Okay, you can see here the deviation is towards the left side. Okay, whenever you take the midline. Okay, so this is very, very important thing for your exam. Okay, very, very important thing for your exam. Then next is they can ask you what is bulbar palsy, what is pseudobulbar palsy. Whenever you have bilateral element type of 9, 10, 11, 12th nerve palsy, then it is going to be bulbar palsy. Whenever you have bilateral UMN type of 9, 10, 11, and 12th nerve palsy, it is called as pseudobulbar palsy. Okay, so the differentiating point is in pseudobulbar palsy, there will be dysphonia. Okay, here it is more of a dysphagia and dysarthria, and dysarthria is little uncommon. Okay, here the gag reflex will be absent, here the gag reflex will be exaggerated. Here jaw jerk will be normal, here jaw jerk will be exaggerated. So இது ரெண்டும் முக்கியம். Absence of gag reflex, exaggerated gag reflex. Absence of jaw jerk, exaggerated jaw jerk. Okay, and another thing is labile emotion. Okay, labile emotion. Labile emotion now in pseudobulbar palsy, yesterday also I told you that whenever there is a pseudobulbar palsy, the patient will be emotionally labile and the patient will start to cry. Okay, so that is very, very important. And they develop a dysarthria called spastic dysarthria. Okay, spastic dysarthria is going to be patient will talk like this. Okay, my name is, okay, like that. Okay, so this is because of the tongue becomes spastic. They cannot rotate the tongue. Okay, tongue becomes spastic. Okay, tongue becomes spastic means they will have a sound which is going to be a spastic in quality. Okay, where you can get in CNS causes like stroke. Usually, bilateral lesion is there. Neurodegenerative disorders, okay, and tumors, okay. So all these conditions you are going to get. You are going to get this pseudobulbar palsy. Whereas bulbar palsy is going to be element type. Okay, so it is seen in conditions like Guillain-Barré syndrome, myasthenia gravis, poliomyelitis. Okay, so you can remember the nerve, neuromuscular junction, and the muscle. Okay, so it is going to be Guillain-Barré syndrome, myasthenia gravis, and element type. Okay, polio. Okay, involves some actually element neurons or anterior horn cells. So it involves in polio. Okay, so இப்படியும் நீங்க பிரிச்சுக்கலாம். Okay, இது வந்து very, very important. Next is coming to the motor. Okay, so motorங்கிறதே ஒரு தனி தனி ஷார்ட் கேஸா வைக்கிறதுக்கு சான்ஸ் இருக்கு. Okay, motor examination. Okay, so whenever you want to examine the motor system, you completely expose the patient while the patient is comfortable. Okay, so you see for any asymmetry. Okay, asymmetry, both proximal muscles and distal muscles. Okay, any asymmetry in proximal muscles and distal muscles, and you also see for the standing posture of the patient whether the patient is having any pes cavus. Okay, any pes cavus. Okay, or patient is having anything like claw hand. Okay, claw hand, club foot, அது மாதிரி வச்சிருக்கான்னு பார்க்கணும். Okay, then examine for wasting or hypertrophy of the muscle, fasciculations in the muscle, or involuntary movement. Okay, involuntary movement. Okay, so this is very, very important. Okay, whenever the foot is high arched with prominent tibia and medial aspect of the thigh. Okay, prominent tibia and medial aspect of thigh, it indicates muscle atrophy. Okay, so this is very, very important. Okay, so இதெல்லாம் வந்து சின்ன சின்ன ஹிண்ட்ஸ் இந்த உங்களோட எக்ஸாமினேஷன்ல ஒரு எக்ஸாமினேஷன் கேட்கப்படுற கொஸ்டின்ல சின்ன சின்ன ஹிண்ட்ஸ். whenever there is a ஹை ஆர்ச்டு ஃபுட், இந்த மாதிரி ஒரு பெஸ் கேவஸ் இருக்கு. ஓகே, இந்த இடத்துல மசில் வந்து ப்ராமினென்ட்டா இருக்கு அப்படி இருந்தா தென் இட் இஸ் கோயிங் டு பி மோர் ஆஃப் அ patient having muscle atrophy, and this muscle atrophy is because of lot of reasons. Okay, lot of reasons. Congenital இருக்கலாம், okay, development anomaly இருக்கலாம், or it can be because of the neuronal lesion. Okay, so first thing is muscle bulk. Okay, muscle bulkல பாத்தீங்கன்னா human lesion இருக்கு, element lesion இருக்கு. Okay, human lesionல பாத்தீங்கன்னா there is going to be no wasting of the muscle. Okay, it is only disuse atrophy. நீங்க யூஸ் பண்ணாததுனால பேஷண்ட் படுத்தே இருக்கனால வர atrophy தான் இருக்கும். அதே elementல there is going to be significant wasting. Significant wasting. Okay, this is very, very important. Okay, very, very important. Okay, then next is whenever a patient has a proximal wasting. Okay, proximal muscle weakness in irundale, proximal muscle weakness or proximal muscle wasting irundale, it is going to be muscle disorders. Okay, proximal wasting or proximal weakness irundale, then it is going to be muscle weakness. Whereas the exception is myotonic dystrophy. Myotonic dystrophy is of distal weakness. Okay, myotonic dystrophy is distal weakness. இதுலயும் ரெண்டு டைப் இருக்கு. M myotonic dystrophyல type 1 இருக்கு, type 2 இருக்கு. Type 1 is distal, which is more common. Type 2 வந்து proximal. இதையும் கேட்க செய்யலாம். Okay, and these patients is also having temporal muscle weakness. Temporalis weakness, and this temporalis weakness is going to give a characteristic appearance in the face called hatchet face. Hatchet face. Hatchet face. Okay, very, very important. Then coming to the patient, okay, how you are going to see the muscle bulk. Okay, so muscle bulk எப்படி பார்க்க போறீங்கன்னா, in upper lip you take a bony prominence. Okay, like olecranon. Okay, olecranon ல இருந்து you go 10 centimeter above. Okay, you check for the circumference, you compare on both the sides. Olecranon ல இருந்து you come 10 centimeter bottom, check for the circumference on both the side. Okay, so olecranon length 10 centimeter above, 10 centimeter below, you go and check for the circumference. Okay, then next is your uh, patient tibial tuberosity. The tibial tuberosity length மேல 18 centimeter, okay, over the thigh. Okay, measure for the circumference, see for any asymmetry, and below 10 centimeter. Okay, iliac tuberosity below 10 centimeter. Okay, அங்க ஏதாச்சும் ஒரு வேரியேஷன் இருக்கான்னு பார்க்கணும். Okay, so whenever it is more than 2 centimeter, okay, variation is there, then it indicates muscle wasting, significant muscle wasting. Okay, then fasciculation. Okay, fasciculation, whenever you see the muscle are going to go for twitching. Okay, this irregular twitches indicate the muscle is under irritation and it is seen in element weakness. Okay, fasciculation is better seen and not felt. Okay, not felt. Okay, then this is going to be very, very important. Okay, so whenever you have sometimes muscle twitching which is seen over the eyelids, okay, it is called as myokymia. Okay, this myokymia usually seen in around the eyes. This is called as facial myokymia. Okay, or ocular myokymia. Okay, ocular myokymia. Okay, then you can also see myoclonic jerks. Okay, myoclonic jerks is jerky movements. Okay, like shivering. Okay, it is a seizure. Okay, it is a seizure. Okay, it is a seizure. So it is nothing to do with our fasciculation. அது ஞாபகம் வச்சுக்கணும். Okay, then next is tone. Okay, what is tone? Okay, tone என்னன்னா tension in a muscle at rest. Okay, or it is a resistance offered by the muscle which is felt by the examiner on passive movement. Okay, it is tension in the muscle at rest, or it is the resistance felt by the examiner on passive movement. Okay, so how you are going to do? You are going to tell the patient to lie down. Okay, lie down like this. Two ways are doing is there in doing this. Okay, so what are the two ways? You keep your hand over the leg and you just rotate it. Okay, chapati அந்த ஒரு இது இருக்கும் இல்லையா, அதை rotate பண்ற மாதிரி you try to rotate like this. Okay, when you try to rotate like this, if it moves flabby, then it is going to be element type of weakness. Okay, element type of weakness, that is going to be hypotonia. Okay, whenever you lift the leg, okay, lift the leg and you drop it, கீழ உங்க கையை வச்சுக்கங்க, you make it drop it. Okay, when it falls flabbily, okay, falls flabbily, then it is going to be element type of lesion, okay. Whereas whenever you lift the leg, okay, and it falls like this, it's going to be flabby type of lesion, okay. இல்லைன்னா என்ன பண்ணலாம், ரெண்டு காலையும் இந்த மாதிரி வைக்கலாம். நார்மல் நம்ம அப்டமன் எக்ஸாமினேஷன் காலை வைப்போம் இல்லையா, அந்த மாதிரி காலை இந்த மாதிரி மடிக்க சொல்லலாம். மடிக்க சொல்லும் போது என்ன ஆகும், whenever there is a hypotonia, the legs will fall apart. The legs will fall apart. Okay, that also indicates that the patient is having element type of weakness. Okay, that also indicates the patient is having element type of weakness. Okay, இது வந்து புரிஞ்சிருக்கும்னு நினைக்கிறேன். The patient has element type of weakness. Okay, அடுத்தது whenever you have a human type of weakness, whenever you lift the leg and drop the leg, it falls like a log of wood. ஒரு மரக்கட்டை மாதிரி மொத்தமா ஒரே மாதிரி வந்துச்சுன்னா, okay, then it is going to be human type of weakness. Okay, coming to the upper limb. Okay, upper limb you can feel the wrist, okay, and the elbow joint. Okay, feel the wrist and the elbow joint. Okay, feel the wrist and the elbow joint. Okay, so whenever you feel the wrist and the elbow joint, you passively flex like this. Okay, so whenever the movement is easy, okay, easy, then it is going to be hypotonia. Whenever it is stiff, okay, it is going to be hypertonia. Okay, hypertonia. Then coming to ankle clonus, நீங்க எங்கேயே பண்ணலாம், பட் ஆனா வந்து இது வந்து it's an exaggerated form of your reflex. Okay, so ankle clonus பாத்தீங்கன்னா, whenever you have a patient like this, you hold the patient like this, leg like this, and you just give a push here. You push over the over the ventral surface, okay, or plantar surface. Okay. Whenever you do like this, whenever you give a jerk like this, the patient leg will go for a pitching like this. Okay. Whenever this movement is 3 to 6, okay, it is called as ill-sustained clonus. Ill-sustained clonus. Okay, whenever it is more than 6, it is called as sustained clonus. Sustained clonus. Sustained clonus is seen in human lesion. Sustained clonus is seen in human lesion. Sustained clonus is seen in human lesion. Okay, so 3 to 6 is ill sustained, more than 6 is sustained. Okay, so இந்த causes எல்லாமே நீங்க படிச்சுட்டு போகணும், படிக்காம போகாதீங்க. Okay, போகாதீங்க. Okay, whenever you have hypertonia, okay, hypertonia, this hypertonia is going to be in upper limb seen as spasticity, rigidity. Okay, this rigidity and spasticity is very, very important, and this is going to be indicating that the patient is having pyramidal tract or pyramidal involvement, and rigidity indicates that there is extrapyramidal tract involvement. Okay, and this rigidity can be further classified into two types. Okay, cogwheel rigidity, lead pipe rigidity. Okay, and spasticity is going to be velocity dependent. நீங்க எவ்வளவு வேகமா மூவ் பண்றீங்களோ அவ்வளவுக்கு அவ்வளவு it is going to change. Okay, so இது எப்படி இருக்கும்னா, initially there will be a resistance and there will be a fall. Okay, that is spasticity. Whereas rigidity ல எப்படி இருக்கும்னா, it is velocity independent. Okay, independent. இது எப்பவுமே வந்து cogwheel டைப்பா இருக்கலாம் இல்ல lead pipe டைப்பா இருக்கலாம். Okay, so this is very important thing. Okay, very important thing. Okay, so இது வந்து நிச்சயமா நீங்க படிச்சுட்டு எக்ஸாமுக்கு போகணும், இது படிக்காம எக்ஸாமுக்கு போகக்கூடாது. Okay, then power. Okay, power you are going to check for group of muscles. Okay, so you tell the patient to contract the muscle and you try to resist it. Okay, you tell the patient to contract the muscle and at the same time you are trying to resist. Okay, contract and resist. So you're going to check over different areas: shoulder, elbow, wrist, finger, thumb. Okay, in the matter you fix the joints, hip, knee, ankle and large toe. In the matter you பண்ணிக்கலாம். Whenever you check the power is going to be graded based upon our Modified Medical Research Council scale. Okay, according to the scale, you have 0 to 5. Okay, 0 is no power, 5 is normal power or normal movement. Okay, 1 is flickering. You tell the patient to move the hand, they will have flickering. Okay, you can see like fasciculation or some kind of the movies எல்லாம் பார்த்திருப்பீங்க, கை மட்டும் விரல் மட்டும் தனியா அப்படியே ஆடும். Okay, that is called flickering. அந்த மாதிரி இருக்கலாம். Okay, or it can be seen eliminating gravity. How will you eliminate gravity? You tell the patient to keep the hand over the chest, okay? Or you keep the patient hand over the chest and tell the patient to extend, okay? Or tell the patient to flex. This is called eliminating gravity. And next is against gravity. Engage gravity, okay? Then R is against resistance. You give a resistance, okay? You give an opposition and then C for it, okay? So this is called as figure. Okay? So this is called as figure. Okay, figure. Then coming to reflexes, okay, the reflexes is of two types. Okay, one is going to be superficial reflex, another one is called deep tendon reflex. Okay, this reflexes is like different ways you're going to record the reflexes. Okay, reflexes. Okay, so whenever you compare with the knee jerk, okay, and it is to the level of knee jerk, okay, then it is going to be 2 plus. Whenever it is compared to the ankle reflex, then it is going to be 1 plus. Okay. So what is this? Okay. Now, reflex can be of different types. Okay, different types. How are you going to present reflexes? So reflexes is going to be whenever you strike a tendon, okay, with a knee hammer, okay, then what is going to happen is the muscle is going to go for contraction. Okay, this muscle contraction, okay, so is going to be important, and that is going to give you a impression whether it is too much or less. Okay, so here there are different ways of grading the reflexes. Okay, different ways of grading the reflexes. Okay, so how you will grade a reflex? Okay, so I will tell you how to grade a reflex. Okay, first is 0, absent. Okay, 0, absent. Okay, 1 plus, okay, it is diminished reflex or hyporeflexia. Okay, 2 plus, normal response. 3 plus, exaggerated or brisk. Okay, exaggerated or brisk. 4 plus, it is associated with clonus. Okay, இது வந்து சொல்லணும். Okay, சொல்லணும். Reflex is absent. Okay, reflex is decreased, reflex is normal, reflex is exaggerated, reflex is associated with clonus. Okay, so this is called as a grading of deep tendon reflexes. Okay, deep tendon reflexes. ஓகே, இது ரொம்ப ரொம்ப இம்பார்ட்டண்டா உங்க எக்ஸாம்ல கேட்பாங்க, நீங்க எக்ஸாம்ல சொல்லணும். ஓகே, எக்ஸாம்ல சொல்லணும். ஓகே, ஸோ இந்த க்ளோனஸ் வந்து சஸ்டெயின்டு க்ளோனஸாவா இருக்கலாம், இல்ல இல் சஸ்டெயின்டு க்ளோனஸாவா இருக்கலாம். இதை பொறுத்து நீங்க அதையும் நீங்க மென்ஷன் பண்ணா ரொம்ப நல்லது. ஓகே, ரொம்ப நல்லது. ஓகே, ஸோ க்ளோனஸ் வந்து எப்பவுமே சஸ்டெயின்டு க்ளோனஸா இருக்கலாம், இல்ல இல் சஸ்டெயின்டு க்ளோனஸா இருக்கலாம். அதை வந்து நீங்க சொல்றது ரொம்ப ரொம்ப இம்பார்ட்டன்ட். ஓகே, வெரி வெரி இம்பார்ட்டன்ட். ஓகே, ஸோ திஸ் ஆர் ஃபியூ திங்ஸ். ஓகே, இந்த ஃபியூ திங்ஸ் வந்து நீங்க வந்து எக்ஸாம்ல வந்து ரொம்ப ரொம்ப இம்பார்ட்டண்டா நீங்க ஞாபகம் வச்சுக்கிட்டு சொல்லணும். ஓகே, ஏன்னா இதெல்லாம் வந்து நிச்சயமா உங்க எக்ஸாம்ல கேட்பாங்க. எக்ஸாம்ல கேட்கும்போது யூ ஷுட் பி ஏபிள் டு டெல் இட். ஓகே, யூ ஷுட் பி ஏபிள் டு டெல் இட். ஓகே, ஸோ திஸ் இஸ் அபவுட் த reflexes. Okay, so இது எங்க பண்ண போறோம்னா we are going to do in different areas of our uh, body. So whenever I'm going to tell you the root value of reflexes, 'the root value of reflexes' is going to be based on the patient's, okay, movement, okay, movement. So whenever I'm going to tell you the root value of reflexes, the root value of reflexes is going to be based on the patient's movement. Okay, so whenever I'm going to tell you the root value of reflexes, the root value of reflexes is going to be based on the patient's response. Okay, and this root value I have taken from a standard textbook like our Dijong. Okay, Dijong is one book which is like our Bible for neurological examination. So அதனால நான் சொல்ல போறது எல்லாமே டிஜாங்ல இருந்து தான் சொல்ல போறேன். ஓகே, ஸோ டிஜாங்ல இருந்து நான் சொல்ல போது டிஜாங் ரொம்ப ரொம்ப நீங்க உங்களுக்கு எக்ஸாம்பிள் கேட்டா கூட நீங்க சொல்லலாம் எங்க இருந்து சொல்றீங்கன்னா டிஜாங். ஓகே, ஸோ here, the biceps is being checked. Okay, so you keep the hand over the bicipital tendon, you give a strike, okay, and you see for the movement. Okay, so the root value is C5, C6, and the nerve is going to be musculocutaneous nerve. Okay, musculocutaneous nerve. Then next is triceps. Okay, C7, C8. Okay, and it is going to be radial nerve. Brachioradialis. Okay, brachioradialis தெரியும் இல்லையா? The கையில just above the wrist. Okay, so it is going to be C5, C6 radial nerve. இது for upper limb. Okay, for upper limb. Okay, coming to the lower limb. Okay, lower limb. Lower limb ல பாத்தீங்கன்னா it is going to be quadriceps. Okay, where it is going to be the knee jerk. Nature, okay, which is going to be having a root value L3, L4, okay, L3, L4, and it is going to be femoral nerve, and it is going to be femoral nerve, okay. Next is sciatic nerve is the one which is responsible for your ankle jerk. The root value is S1, okay. So you remember S1, L3, L4, C5, C6, C7, C8. Okay, so 2 is missing. Okay, 2 is missing. Okay, S1, L3, L4, C5, C6, C7, C8. Okay, இந்த மாதிரியும் நீங்க present பண்ணலாம். Okay, இந்த மாதிரியும் நீங்க present பண்ணலாம். Okay, so these are few important things for your exam. Okay, so இது படிக்காம நீங்க எக்ஸாமுக்கு போகக்கூடாது. Very, very important. Whenever you are not able to do, you can go for reinforcement also. Okay, then next is superficial reflex. Okay, superficial reflex. Whenever you come to superficial reflex, okay, superficial reflex, how we are going to examine for the superficial reflex. Okay, first is plantar response. Okay, plantar response, very, very important. Plantar response on the S1 and S2. Okay, and few books says L5, S1. Okay, so you go for L5, S1, that will be better. Okay, L5, S1. Okay, so whenever you take the plantar reflex, you start from the lateral aspect and go till the second toe. Okay, so whenever you run a blunt object, okay, there will be extension of big toe. Okay, and along with that there will be fanning of other fingers. Apart from this, what you will have is whenever there is a plantar response, there is going to be one extension of great toe or big toe, fanning of fingers, flexionate, ankle joint, knee joint, hip joint, and contraction of tensor fascia lata. Okay, tensor fascia lata. That is, you see the later part of there, you have the tensor fascia lata. The tensor fascia lata இழுக்கிற மாதிரி ஒரு ஃபீலிங் இருக்கும். இதுல ஏதாச்சும் ஒன்று நடந்தா, எக்ஸ்டென்ஷன் ஆஃப் கிரேட் டோ மட்டும் நடந்தா, இல்ல ஃபேனிங் ஆஃப் டோ மட்டும் நடந்தா, okay, or there is going to be dorsiflexion of the ankle, இந்த மாதிரி ஏதாச்சும் ஒன்று நடந்தா, then it is going to be equivocal. Okay, and it is called as equivocal. Okay, equivocal response. Okay, equivocal response. Okay, then next is abdominal reflexes. ஓகே, இந்த ஈக்குவலன்ஸ்லாம் நீங்களே படிச்சுக்கலாம்னு நினைக்கிறேன். கோண்டா சைன், கோண்டா சைன், ஷாஃபர் சைன், இந்த மாதிரி ஈக்குவலன்ஸ்லாம் நீங்க படிச்சுட்டு போங்க எக்ஸாமுக்கு. ஓகே, வாட் ஆர் த பிளான்டார் ஈக்குவலன்ஸ் ஆர் பபின்ஸ்கி ஈக்குவலன்ஸ்? இது படிச்சுட்டு போகணும், படிக்காம எக்ஸாம் போகக்கூடாது. ஓகே, ஸோ இது படிச்சுட்டு போங்க எக்ஸாமுக்கு. ஓகே, ஸோ தட் இஸ் வெரி, வெரி இம்பார்ட்டன்ட். ஓகே, Then coming to abdominal reflex, okay, abdomen, if you take, this is the end of the sternum, and this is the pubic symphysis. So the root value is from T8 to T12, okay. So pubic is T6 to T12. Okay, you can rather go to T6 to T12. That is will be easy. Okay, T6 to T12. Okay, and if it is going to be here, T10. Okay, T10. Okay. So T6 to T8, in சில புக்ஸ்ல வந்து இப்படி கொடுத்திருக்காங்க. So you go like this, okay. So here, whenever you strike away from the umbilicus, okay, whenever you strike away from the umbilicus, you can see the contraction in that part of the abdomen, okay, that part of the abdomen, okay. So whenever you see this umbilicus is a muscle, this umbilicus muscle will be pulled towards that side, okay. Whenever it is absent, okay, then it is going to be superficial reflexes absent. Whenever you have superficial reflexes absent, okay, then deep tendon reflex absent, then it is going to be element type of lesion. Whenever you have a human type of lesion, it is going to be superficial reflex is going to be absent and deep tendon reflex is going to be exaggerated. Okay, exaggerated. That is going to be seen in deep tendon reflexes. Okay, so with this we are finishing the examination of motor system. Okay, இதுல next வந்து sensory system மட்டும் நான் சொல்லிடுறேன். சென்சரியில வந்து ஃபர்ஸ்ட் வந்து லைட் டச். லைட் டச் எப்படி பண்ணோம்னா, யூ டேக் த காட்டன், ஓகே, அந்த காட்டன்ல வந்து இந்த மாதிரி ஒரு விஸ்ப் மாதிரி ஃபார்ம் பண்ணணும். ஓகே, இந்த விஸ்ப் மாதிரி ஃபார்ம் பண்ணிட்டு பேஷண்ட் ஐஸை க்ளோஸ் பண்ண சொல்லிட்டு யூ ஹேவ் டு டச் அண்ட் சி அண்ட் கம்பேர் ஆன் போத் த சைட்ஸ். That is going to be light touch. Then superficial pain. You take a pin, okay, and with the pin you just prick in different areas and see for whether the patient is able to perceive the pain. Okay, temperature. Temperature வந்து you use anything which feels cold. Okay, usually 4 degrees Celsius, 37 degrees Celsius. This is for hot, this is for cold. So உங்க கையில நீங்க ஐஸ் வாட்டர் எடுத்துட்டு போலாம், இல்லைனா you can take hot water, okay, or you can take a tuning fork, okay. இந்த tuning fork ஓட ஒரு ஜில்லுன்னு இருக்கும், அந்த ஒரு ஃபீல் வச்சு கூட பண்ணலாம், okay. பட் ஆனா ஐடியலா அப்படி பண்ணக்கூடாது, okay. பட் எக்ஸாம்ல வேற வழி கிடையாது, நீங்க கொண்டு போகாட்டி அந்த ஹாட் வாட்டர் வந்து கோல்டா மாறிடும், ஓகே. கோல்டு வாட்டர் நார்மல் வாட்டரா மாறிடும். ஸோ அதனால வந்து யூ ஹாவ் டு use some other handy methods, okay. So tuning fork will be better, okay. Then vibration, okay. So என்னன்னா கோல்டு அவர் பர்சீவ் பண்ண முடியலன்னா ஹாட்டும் பர்சீவ் பண்ண முடியலன்னு அர்த்தம், we can assume, okay. பட் ஆனா நீங்க எக்ஸாமினர்ட்ட நீங்க சொல்லணும், okay. Then vibration 128 hertz, okay, 128 hertz using, okay. So இங்க பாத்தீங்கன்னா இந்த சென்சேஷன் நீங்க எப்படி பண்ண போறீங்கன்னா, போனி ப்ராமினன்ஸ்ல நீங்க டியூனிங் fork வைக்கணும், whether the patient is able to perceive the sensation or not, okay. And you are going to use 128 hertz, and usually diabetic peripheral neuropathy it will be affected, where distal part is affected followed by proximal part. அதனால always check for the distal part first followed by proximal part, okay. So in diabetic neuropathy you are going to get distal, symmetrical, sensory motor polyneuropathy அது பார்க்கணும், okay. Then joint sensation எப்படி பண்ணணும்னா, ஒரு பேஷண்டோட ஜாயிண்ட் வந்து நீங்க ஹோல்ட் பண்ணிக்கணும், மற்ற ஃபிங்கர்ஸ்லாம் டச் பண்ணாம ஹோல்ட் பண்ணிட்டு நீங்க வந்து கீழே மூவ் பண்ணா 1, மேல மூவ் பண்ணா 2. ஸோ பேஷண்ட் ஐஸை க்ளோஸ் பண்ண வச்சுட்டு யூ ஹேவ் டு டெல் 1 or 2, ஓகே, அப்படின்னு சொல்லணும். நெக்ஸ்ட் வந்து பொசிஷன், ஓகே. பொசிஷன், how will you do position sensation, okay. Position, okay. Now what happens is you keep the patient hand like this, okay. Tell him to bring towards the midline, okay. If he's able to bring the hands to midline on closed eye, then his position sensation is intact, okay. Or patient வந்து இந்த கையை இப்படி வச்சிடுங்க, வச்சுட்டு இந்த கையும் அதே பொசிஷன் வைக்க சொன்னீங்கன்னா அதுவும் பொசிஷன் சென்சேஷன், ஓகே. இப்படிதான் நம்ம பொசிஷன் சென்சேஷன் செக் பண்ணணும், ஓகே. பொசிஷன் சென்சேஷன் செக் பண்ணணும், ஓகே. So this is very very important, okay, very very important thing. So with this, okay, almost I have covered everything, I think so, okay. So நான் இங்க வந்து உங்களோட பபின்ஸ்கி ஈக்குவலன்ஸ் சொல்லிடுறேன், okay. So whenever you strike towards the heel of the டிபியா. ஓகே, டிபியா மேல அப்படியே கையை உரைச்சிட்டே வந்தீங்கன்னா அதுக்கு பேர் வந்து ஓப்பன் ஹீம் டெஸ்ட். ஓகே, ஓப்பன் ஹீம் டெஸ்ட். ஓகே, then you squeeze the calf muscle, gordon. You squeeze the Achilles tendon, Schaffer. Okay, Schaffer. Chaddock. Chaddock வந்து lateral border of the foot, okay, or along the malleolus, okay, malleolus, lateral malleolusல ஒரு C மாதிரி போடுங்க. அந்த மாதிரி போட்டா Chaddock's, okay. So these are the Babinski equivalents, okay. These are the Babinski equivalents. The Babinski equivalents எக்ஸாம்ல ரொம்ப ரொம்ப இம்பார்ட்டண்டா நீங்க சொல்லணும், okay, ரொட்டீன் இம்பார்ட்டண்டா சொல்லணும். Okay, so this is going to be the most important thing for your exam. Okay, CNS வந்து gross-ஆ நம்ம finish பண்ணிருக்கோம். Okay, 1 hour of CNS or 1.5 hours of CNS is one Herculean task. Okay, the Herculean task we have tried to uh, reinforce what are the important areas. Okay, இதெல்லாம் படிச்சுட்டு நீங்க எக்ஸாமுக்கு போகணும். So you will get this PDF. Okay, so you read well. Tomorrow we will have abdomen examination. Okay, and then day after tomorrow we will have X-ray. Okay, thank you all. Okay, so exam to prepare பண்ணுங்க. All the best for your preparation. Okay, all the best for your preparation. Thank you.